Hello students. Today we'll be talking about local anesthetics. Now, what do you understand by the terminology local anesthesia? Now, anesthesia is a Greek word which means an means without and aesthesis means feeling or sensation. So local anesthesia or local anesthetics are nothing but drugs which when you apply topically or you're going to inject them as a local injection, they are going to cause a reversible loss of sensory perceptions. And what do you mean by sensory perceptions? There are many things like pain, touch, pressure, temperature. So the main use of local anesthetics is to relieve a person from the local pain. And how are they going to do it? By blocking the generation or the conduction of a nerve impulse, whichever they're going to come in contact with, but very importantly, without causing any amount of structural damage. So, this is local anesthetics. Now, we have many types of local anesthetics, and let us understand the basic chemistry of local anesthesia. Uh, if you are going to classify them based on their chemistry, then you have two types. They are called as ester-linked local anesthetics or amide-linked. Now, what is the way? How do you remember it? The simple rule of thumb happens to be that any anesthetic having a single eye becomes an ester-linked local anesthetic, and that with a double eye becomes an amide-linked local anesthetic. So you have cocaine, procaine, tetracaine, and benzocaine, which are having a single eye, and therefore they are ester-linked local anesthetics. Whereas your amide-linked drugs are those which are having two eyes. You see over here. Okay. So coming to talking about the general, chemistry of your local anesthetics. So you know that these are weak bases, and they have both a hydrolipophilic group, and you have the hydrophilic group, and these are together linked by a bond. And depending upon the type of the bond, whether it is ester linked or amide linked, you are having the two types of local anesthetics. So basically remember, these are weak bases. Okay, then which amongst these do you prefer? So we ideally go for the amide linked local anesthetics, so those with a double eye, lidocaine, then bupivacaine, ropivacaine, all of these are preferred. Why are amide linked local anesthetics preferred? Because they have a very intense and long lasting anesthesia, and they are not hydrolyzed by plasma esterases. So, as the name is itself suggesting to you that esterases or the ester linked local anesthetics are broken down by plasma esterases. But here, these amide linked drugs need not have to depend on plasma esterases, but they are metabolized. So, for that reason, they have a longer T half. And these amide linked, they bind to the alpha 1 acid glycoprotein, and most importantly, something that gives edge over your ester linked local anesthetics happens to be that the hypersensitivity reactions are very rare, and there is no cross sensitivity with your other ester linked local anesthetics. That is the reason why we prefer amide linked drugs over your ester linked drugs. The second way of classification includes the type of administration. So either we are going to inject it around nerve or we are going to apply it topically. So the best example happens to be the eye drops what you put before you go in for an ocular surgery, or before you get a tonometry done, or a measurement of the pressure, intraocular pressure done. So those are called as surface anesthesia, or something what you want to numb, topical application. So that is surface anesthesia. Whereas your injectables, we are going to inject it around a nerve. So these are classified again based on the potency and the duration of action. So those drugs with a low potency and short duration of action, they are procaine and chlorprocaine. Those with intermediate potency and duration are your lidocaine, prelocaine, and mepivacaine. And those with high potency and long duration of action are your tetracaine, bupivacaine, and dibucaine. So again, depending upon the solubility, they are classified as soluble and insoluble local anesthetics. You can see over here there are a few insoluble ones which are not absorbed, and the rest of the things are soluble. Now, as I've already mentioned, local anesthetics are weak bases. So what do you understand? So if you remember my class on pH and the ionization constant, the pKa, if you remember the Henderson-Hasselbalch equation. So what does that say? pH is equal to pKa plus log of the unionized by the ionized concentration, isn't it? So these are bases, weak bases. So what ideally happens, like when you meet an acidic pH, obviously they're going to be dissociated. So more of it is going to be in the ionized form, thereby it is going to reduce the entry through the lipophilic membranes. Okay, so the non-ionized form, when it is equal to the ionized form, that is the dissociation constant. So higher ratio of ionized medication compared to non-ionized medication happens when you encounter, or when these encounter a pH which is almost equivalent to that of plasma. The onset of action also depends upon the pKa. So what do you understand by this? Local anesthetics with a pKa equivalent to the physiologic pH have a higher concentration of non-ionized base, resulting in a faster onset. This is because an unionized drug enters the cell very quickly and it will have a faster onset. But please remember, once it enters, when it enters within the interior of the cell, at the pH of 7, it becomes ionized, and it is this ionized drug which finds its place within the receptor for the local anesthetic. So, what are the clinical implications of whatever we studied so far? Local anesthetics, especially in an acidic pH. In an acidic pH, obviously, you need more of a local anesthesia to exert its numbness effect. Okay, so lignocaine, it is a weak base drug, so 7.9. So most of the drug is going to remain in the unionized form, so it is going to have a faster onset of action. And you know this statement, right? Weak bases are better absorbed when the pH in basic medium, so when the pH is greater than the pKa. So whenever there is inflammation or an acidic pH, the pH is going to fall. This results in a higher ionization. So the ionized drug will be more, therefore you need a higher concentration of the local anesthetic to exert its action. Now, understanding the mechanism of action. Now you know there are many types of channels. You have the sodium channels, calcium channels, potassium channels, and so on. Now these local anesthetics, they act on the sodium channels. What are they going to do on the sodium channels? What is the net effect of blocking the sodium channels? You know that sodium is required for this rapid depolarization. You know there are phases of depolarization and repolarization in any case of a fiber. So if it is a nerve fiber, it has a faster action. I mean to say, the lag phase is less, and also the duration of the impulse is less when compared to the cardiac muscles. Cardiac muscles usually have a plateau phase, but a nerve doesn't have it, isn't it? You know that. So the phase 0 and the upward rapid upstroke, which is responsible for the depolarization, is brought about by your sodium channels. Now, by blocking the sodium channels, what are these local anesthetics doing? They are reducing the sodium ion entry during the upstroke of the action potential. So because of this, what happens? You are actually raising the threshold. Now, what do you understand by the statement raising the threshold? It means that you are making the slab higher than the previous one. So when you make something like a barrier, you increase the height. What happens? You need more of energy to cross it, isn't it? So similarly, what happens when you're blocking the sodium channels? The threshold gets raised. So many of the nerve impulses which do not reach this threshold will not be conducted as an impulse. Because of that, the person is not going to sense pain. So this is one of the main mechanisms of actions of local anesthetic by reducing the sodium entry during the rapid upstroke of action potential. That is happening because of raising the threshold. So this is the sodium channels. I told you local anesthetics are your sodium channel blockers, isn't it? So what do? It is the unionized drug which is going to traverse through the membrane. And this drug, on reaching the inside of the cell, what happens? It dissociates. So it is the ionized drug. Now this ionized drug finds its way finds its way to the receptor. So you see here, this is the receptor for the local anesthetic. And what does it do on entering this? It is going to act on the sodium channels. So local anesthetics bind to the channel 4 and block the entry of sodium channels. So these sodium channels, they exist in three states. You have to remember this, okay? So what are the three different states of sodium channels? It exists in the resting state, activated state, or the inactivated state. See, just like you tend to take a break in between classes, isn't it? So that is your resting state. Now, why do you need a rest between two classes? To energize, to rejuvenate yourself. So similarly, the sodium channels also, once after being in a state of activation for some time, they go to the inactivated state and then get back to the resting state. What happens if there is no recovery at all? There is no chance for a further impulse generation to occur, isn't it? So these local anesthetics, they are going to bind very avidly to either the activated state or the inactivated state of the sodium channels, and they inhibit or they delay the recovery of the channels to the resting state. Thereby, they're going to reduce the frequency of impulse generation. I hope you got this point. Local anesthetics, they block the open or the inactivated sodium channels, and they have very little affinity for channels in the resting state. Thereby, they're going to prolong the recovery of the channel. This prevents the generation of the impulse. So having understood the mechanism of action, let me quickly take you to a case scenario of a first year medical student who accidentally spills some kind of a chemical which is a corrosive on her right hand fingertip. So she feels the stinging pain initially, followed by a throbbing ache. The main point which I want you all to focus over here is that there are different types of pain sensations, and each of these is carried by different nerve fibers. You're all fresh from physiology, and you know that you have the different types of pain carrying fibers like the C fiber, A delta fiber, and so on, isn't it? So they carry the sharp pain, and the throbbing pain is usually carried by bigger nerves or the huge nerves, myelinated nerve fibers. So now she is now taken to the emergency department, and where the resident notices that because of the deep penetration of the acid, she is experiencing severe pain. And this person is trying to perform one of the methodologies involved in local anesthesia administration, which is called as the digital nerve block. And what did he choose to do this? He chose lidocaine without epinephrine. So why I want you all to focus over here, why are local anesthetics combined with vasoconstrictors like epinephrine? In this case, why wasn't it preferred? And then what do you see? The person, she notices a relief of the stinging pain first, although the ache takes a longer time to subside. And after some time, she cannot feel any sensation in fingers at all. So, the main idea of this case is to highlight why was there a difference in noticing a relief in stinging pain, which was earlier than your dull aching pain. Second point is, why is epinephrine usually added to local anesthetic, and in this case, why was it not co-administered? So over the next few minutes, we are going to look into these three questions and try to find solutions. So local anesthetics are not just selective for pain, they are also block the other sensory, what do you say, sensations like your touch, temperature, pressure, and so on. And if it happens to be a mixed nerve, then they also block the motor nerve impulses. In addition, they have their effect on the autonomic fibers, and also they can block the skeletal and the cardiac muscles. But there is a different pattern in their affinity towards the various nerve fibers. Now, what do these local anesthetics do? I told you any local anesthetics they cause reversible loss of sensation without causing any structural damage. This is something what you have to remember very much. Once the effect of the local anesthetic is lost, definitely pain impulses will again be generated. The person who you have a piece of ice, you keep a piece of ice on your thumb for some time. You're on your tongue, okay, sorry, on your tongue for some time. The tongue is going to become numb for some time, and then will the numbness is going to persist throughout? No, you get back it, you get that back, isn't it? So keeping of ice is almost similar to anesthetizing that surface by using local anesthetics. So there is a reversible loss of sensory perception. Now, these local anesthetics, they reversibly bind to the voltage gated sodium channels, and they're going to block the entry of the sodium ions into the channel, and thereby they're going to inhibit the propagation of action potentials along the neuron. So you know these are the nodes of the ganglion, and over here there are more of your sodium channels getting concentrated. And if at all propagation failure has to occur, then the local anesthetic must be um, causing, or anesthetizing at least a minimum of 2 to 3 nodes of ganglion. So this is the rule for the local anesthetic to be acting. So what is the effect on the nerve trunk? So if at all you're going to inject the local anesthetic around a peripheral nerve, so it is ideally the epineurium which is going to be affected first, followed by the perineurium and the endoneurium. So you know how is the distribution of the nerves on these areas. So you know the upper limb anatomy, and you know that the proximal areas they are present peripherally, whereas the distal areas nerve supply is present within the um, in the inner part of the central part. Therefore, the proximal areas are first numbed before the distal areas. So this is how local anesthetic effect progresses. And we also have what is called as the differential functional blockade. So pain, which is carried by the A delta and the C fibers, are lost first when compared to the temperature, followed by touch and pressure. And finally, it is the muscle tone and the voluntary tension which tends to get affected. So if at all you're going to apply local anesthesia on your tongue, it is the bitter taste which is lost first when compared to sweet, followed by sour and your salty taste. Then, answering my second question, I hope we have answered why the a stinging sensation that was first lost. You know, it's usually the myelinated fibers which are anesthetized faster than the unmyelinated fibers, and smaller the diameter of the fibers, they are the ones which are fast affected when compared to larger diameter fibers. Next, moving on to the second question, why should local anesthetics be combined with vasoconstrictors? So you know by now what is adrenaline. Adrenaline is a vasoconstrictor. So if at all we are combining, what should be the concentration? So adrenaline is usually used at a concentration of 1 in 50,000 to 1 in 2 lakh. So what are the advantages? So it's a vasoconstrictor. So you're going to reduce the blood flow. So if there is reduced blood flow, absorption is going to be less. Systemic absorption is not going to be happening. The anesthetic is going to remain localized. That is your intended site of action and your intended plan of action, isn't it? So you want the drug to stay at the local site for a longer time. For that reason, you're using a vasoconstrictor, which is going to reduce the systemic absorption. So when there is a reduced systemic absorption, obviously the side effects are going to be less. and more of neuronal uptake is going to happen. The localized nerves which are going to there, they're going to take up the drug at a faster rate. So you are going to have a depth of anesthesia, and you are going to reduce the dose of the local anesthetic. And prolonged duration of action occurs. You're not removing the drug is going to stay at that place for a longer time. So this is going to enhance or improve the duration of action of the drug. And as I mentioned, no systemic absorption or reduced systemic absorption is going to reduce the toxicity. And the combination of this is mainly used for providing a bloodless field of surgery. For some of the surgeries, you need a bloodless field. So for that reason, you would be employing a local anesthetic with a vasoconstrictor. But this technique is not without its disadvantages. So this, when you use this technique, the injection is going to be very painful. And if there's going to be some kind of an extravasation, then local tissue necrosis and edema is bound to happen. And if at all adrenaline gets systemically absorbed, you know, sympathomimetic drug. So what does it do? It's going to increase your BP, it can promote arrhythmia, and so on and so forth. So these are some of the disadvantages of combining adrenaline with the local anesthetic. Then, so what are the systemic actions? Um, First, if at all the absorption is going to happen, so there's going to be a CNS excitation followed by depression. So first is your cardiac, next is your cardiac depression, and arrhythmias are bound to happen. So um, with adrenaline. So these local anesthetics, especially lidocaine, it is one of the class 1 antiarrhythmic agent. So this is mainly used for the treatment of ventricular tachycardia and ventricular tachyarrhythmias. Okay, so lidocaine is a class 1 antiarrhythmic drug. It is used for the treatment of arrhythmias. Then on the blood vessels, it is going to reduce the blood pressure. Coming to the third question, why should the combination not be used in this condition wherein the person was having injury on the finger, okay, fingertip. So you've all heard about the end arteries, isn't it? In anatomy class, you've heard about the end arteries. Now, end arteries are where you don't have any kind of anastomosis happening. So they are the crucial vessels which are needed to prevent ischemia of the supplying area, isn't it? So in that case, if you tend to give a vasoconstrictor, then what is going to happen? Ischemic changes are going to happen. So never use a vasoconstrictor when you're giving it for end arteries. So which are the places with end arteries? One is your fingertip, the other is your pinna, ear pinna, tip of the nose, and also penis. Okay, in such places, you shouldn't be giving adrenaline mixed with a local anesthetic. And the adverse effects, as I have already mentioned, wound healing could be delayed, and certain drugs like bupivacaine can cause local tissue irritation. And hypersensitivity reactions, though less with the mild, we can't be totally ruling it out. So let's talk about the individual compounds. The first thing what people were using as a local anesthetic was cocaine. You know, this was used as it was a herb which was found in South America, Peru, and people were chewing it as a drug of abuse. You know very well, it's a drug of abuse. So when they were chewing it, they used to feel loss of sensation in the tongue. So they used to have a numb tongue. So that was how the local anesthetic effect of cocaine was found. But it's not used anymore, especially it's not used as IV mainly because it's a protoplasmic poison. And as you all know, it's a drug of dependence, and it causes CNS stimulation. It also has sympathomimetic properties also. So therapeutic use, if at all, but I really doubt we have better surface anesthetics available. So cocaine is hardly in use. It could be limited to your ocular use. So the limitation happens to be the tissue toxicity, which I told you, it is a protoplasmic poison. Next is your lidocaine. Now, lidocaine is something which we use very frequently in our clinical practice. It is also called as lidocaine, and xylocaine is the brand name. So whenever you go to your casualty postings or anywhere, surgery postings or ophthal postings, ENT postings and all, you will be using the local anesthetic usage over there. Please remember, lidocaine is the most frequently used drug and it is the prototype drug. So this is amide linked and it has a very fast onset of action and a longer duration of action. Other than its local anesthetic use, it is used as an antiarrhythmic drug, which I was telling you, it's a class 1 antiarrhythmic drug used for the treatment of ventricular tachycardias and has a wide variety of action. I'm going to enumerate a few of them. Prelocaine is something, one more drug, which has low CNS toxicity, but one of the complications associated with the use of prelocaine happens to be methemoglobinemia. So this is again used for infiltration, injectable drug. It's an injectable drug. Most importantly, you have to remember the combination of lidocaine with prelocaine is called as a eutectic mixture. This comes as a 3-mark question. I'm going to explain to you in my next slide what is a eutectic mixture. So as of now, remember, lidocaine plus prelocaine forms a eutectic mixture. The next drug which you all have to pay attention and which you'll be seeing the use in OBG postings happens to be your bupivacaine. We call it Sensacaine. It's the trade name. Okay, so bupivacaine is one of the long-acting local anesthetic and it is available in various concentrations, but the most frequently used concentration happens to be 0.25 to 0.5%. Now, this is one of the drug which has a unique ability. It is the one which gives you analgesia without significant motor blockade. I hope you understand what I mean by this. See, it is causing loss of pain sensation, but it is not hampering your motor impulses. So, what is the advantage of using this drug during labor or childbirth? The lady is not feeling pain, but she is still able to take part in the labor process. You have seen a labor process happening, so it is the combined effort of the uterine action because of oxytocin and also the lady's mechanical efforts of trying to push down the fetus. So the lady is definitely not in pain, but at the same time, she is able to take part in the labor process. So this is one of the advantages of having bupivacaine for epidural anesthesia. But one of the disadvantages with bupivacaine is that it is not used for intravenous regional anesthesia. So what is IVRA? I'm going to talk about it a little late. So far, as of now, please remember bupivacaine is something which is used very commonly for obstetric purpose, and it is also used for spinal anesthesia. Okay, so infiltration, nerve block, epidural, and spinal anesthesia are its therapeutic applications. The main limitation associated with bupivacaine happens to be your cardiac toxicity. So that is the main reason as to why we don't use it for intravenous regional anesthesia. Next is ropivacaine. It's a congener of bupivacaine, but compared to its predecessor, it is less cardiotoxic. So this is again finding its place in postoperative as well as labor pain. So coming back to the point on eutectic mixture, so I was telling you it's a combination of lidocaine and prelocaine. So when you combine both of these drugs, what happens? You're lowering the melting point of these two solids. So you're mixing them in equal proportion at a temperature of 25 degrees, and by that you're going to reduce the melting point of these two solids. So the resulting emulsion, whatever is being formed, that could be used as an occlusive dressing. And where can you use it as an occlusive dressing? Maybe before cannulation, IV cannulation, you have to be using it 1 hour prior. So this is the only preparation which could be used on an intact skin for split skin grafting, split skin graft harvesting. So this is one of the options for an alternative for using lidocaine infiltration. You see, this is the drug or the combination which is used to anesthetize an intact skin, and this provides anesthesia for up to 5 millimeter depth. Then talking about the uses and also the techniques, various techniques which are employed. So the best thing is you have to read this, and you also have to attend your postings in the casualty department, where they will be doing a lot of suturing, where they would be injecting local anesthesia, or in the minor OT or as well as the major OT, wherein they'll be giving epidural, spinal. So just focus on the various techniques which are used when you are injecting the drug. Okay, so surface anesthesia, very commonly seen. You're going to see this in your ophthal and your ENT postings also. So the topical anesthesia used on the eye, and we also have a rabbit eye experiment of local anesthesia. So there you would be seeing where we are going to use it as a surface anesthetic. So again, lipid soluble membranes, the absorption is going to be very fast, and if at all you have to anesthetize intact skin, then you would be using a eutectic mixture. The various drugs used are tetracaine, lidocaine, then oxytocin. So oxytocin is something what you have to pay attention. This is used to anesthetize your gastric mucosa. So it's usually combined with your antacid syrups to anesthetize the gastric mucosa, which is usually given to people with severe gastric ulcer and peptic ulcer disease. So they have a lot of pain associated due to the ulcer. At that moment, you could be using. So the other things like benzocaine, butambin, and many other things, they're going to anesthetize the oral cavity for intubation, laryngoscopy, and many other things. You're going to be using them. Then is your infiltration anesthesia, which is usually done during dental extraction. So what we do over here is we are going to dilute the solution of the anesthesia, and we are going to just infiltrate it under the skin, so that we are going to anesthetize the whole bunch of the sensory nerve endings which are going to infiltrate that particular space. So this, when compared to your nerve block, which I'm going to talk about in my next slide, the duration of action is smaller, and minor surgeries like your uh, hernia surgery, hydrocele or excisions, there you could be using it. The drugs commonly used are lidocaine and bupivacaine. Next is your conduction block. So conduction block mainly consists of two types, um, nerve block and field block. Okay, so we use lidocaine and bupivacaine for this action. So what we do over here is we are going to inject the drug around the nerve trunks. So you have your brachial plexus. That's a huge trunk, isn't it? Nerve trunk. So when you are going to inject it around the entire nerve trunk, so that is one of the ways of causing a conduction block. So you have the field block. So all the nerves which come to a particular area are getting blocked. So I gave you the example of the fingertip, isn't it? So that is the example of a ring block. So we are using, by using a small quantity of local anesthetic, we are going to anesthetize a larger area. This is the field block technique. The next is the nerve block technique, where we are going to inject the local anesthetic along the trunk. Okay, appropriate nerve trunk. So you have the brachial plexus block or the ulnar blocks. If when you have sciatica, there you're going to block the sciatic nerve and so on. So this is the nerve block technique. Spinal anesthesia. So this comes as a 5-mark question. So what you have to do is, what is spinal anesthesia? So it's nothing but injecting the local anesthetic into the subarachnoid space. And where are you going to do that? Within the space L2 and L3, that is the lumbar segments, second and third. So you're going to inject this into the subarachnoid space. So along with the autonomic fibers, all the other types of fibers are also going to be affected, but it is ideally the autonomic fibers which have a higher sensitivity when compared to your cutaneous as well as motor fibers. So it's usually a 2-segment higher. And you can this technique is mainly used for anesthetizing the lower abdomen and also the lower limbs. So that is why anything like a pelvic surgery or a lower limb surgery, you would be using a spinal anesthesia. You could also be using adrenaline, the same mechanism of using a vasoconstrictor to prolong the duration of action. And in addition, adrenaline, because of its activity on your alpha 2 receptors, has an additional anesthetic value. And whenever you're using this in a pregnant woman, you have to be careful, because the inferior vena cava is going to be compressed because of the growing, enlarging uterus. So you'll be using, in fact, a lesser quantity of local anesthetic whenever you're using in pregnant women. So it's mainly used for operations on lower limbs and also the pelvis. Spinal anesthesia, even though technically it is easy, it's associated with a lot of complications. So some of them happen to be hypotension. This is mainly due to blockade of your autonomic nervous system. You also have something called as the Cauda equina system. Syndrome. So, what is this Cauda equina syndrome? Is the person after having the spinal anesthesia is going to face a terrible headache and and there is going to be loss of bladder control. This is mainly because of arachnoiditis. Okay, the infection, the inflammation, which is going to happen. So there is loss of your bladder control. Ideally, after giving spinal anesthesia, there's loss of control, but the person is not going to regain it immediately in case of Cauda equina syndrome. So the other complication happens to be your septic meningitis or after meningitis. As I mentioned, headache is very common and nausea, vomiting. Sometimes I told you these segments, the autonomic blockade is usually two segments higher. So respiratory paralysis is one of the complications if at all you're not very careful in calculating the ascent of local anesthetic. Then is your epidural anesthesia. Now, epidural anesthesia, so as the name is itself suggesting, it is injecting the local anesthetic into the epidural space. So again, your epidural space, you have the thoracic space, the lumbar space, and the caudal or the sacral space. So when compared to your spinal anesthesia, this is difficult. Technically, this is difficult, but it has a lot of advantages, especially when you're giving 0.25% bupivacaine for obstetric purpose, which I've already mentioned. There's going to be a distinct demarcation between sensory loss as well as the motor impulses. So the lady can still participate or actively take part in the labor. And when compared to a spinal anesthesia, headache and neurological complications are going to be less. So epidural anesthesia, though technically difficult, it has a few advantages. The last thing what I would like to talk about happens to be the intravenous regional anesthesia, also called as the Byers block. Now, this you have videos which are uploaded in YouTube, which show you how this technique is being performed. See, until you see that it is being performed, you would not be understanding the nuances of this procedure. But never mind, I'm going to try to explain this to you all. So you are going to use this technique mainly for upper limb procedures and also for orthopedic procedures. So what you're going to do is you're going to elevate the limb, try to drain off the drainage, okay, the venous drainage, and then you're going to wrap, what do you say, a bandage over it, rubber bandage over it. Again, this is to squeeze off the remaining vascular drainage, and then you're going to apply a tourniquet. Then you're going to inflate the tourniquet, and when this is happening, we're going to inject the local anesthetic IV distally. So regional anesthesia, you can be using, you could be attaining it within 2 to 5 minutes. You can't be keeping it for a long time because again the procedure could be hazardous if there is going to be an ischemic injury. And more importantly, bupivacaine cannot be used mainly because of its higher cardiac toxicity. So in today's class, we have discussed about the various classification of local anesthetics. We have understood local anesthetics have a differential blockade capacity. Then in not just to sensory, they also tend to block the motor impulses. We have understood what is the advantage and disadvantage of combining vasoconstrictor like adrenaline with local anesthetic. We have understood the therapeutic uses and also the various techniques in which local anesthetics are being used. So, and 3-mark question, eutectic mixture, 5-mark question, spinal anesthesia. These are some of the things which could be expected, and also give reasons, disadvantage or advantage of combining local anesthetic with adrenaline. So these are some of the important questions, and you also have a 10-mark exercise in your practical exams on computer assisted learning based on local anesthesia. So from that point of view, this happens to be an important chapter. So I hope you've understood everything, including the mechanism of action, because you will be using the same mechanism of action while discussing about the antiarrhythmic drugs in your further CNS classes, CVS classes. Okay, thank you so much.